Okay, this is Adult Nursing 1, NURS209. We'll be looking at the cardiovascular system part 1, and today we'll be discussing cardiac rhythms, hypertension, and sickle cell, as well as MI and coronary artery disease. The objectives will be twofold. You're going to be looking at the normal sinus rhythms, and then you're going to be looking at some dysrhythmias. So what we're going to do is we're going to identify the following normal sinus rhythms, which is sinus rhythm, tachycardia, and bradycardia. And we're going to identify the abnormal rhythms, which will be atrial fibrillation, atrial flutter, and ventricular fibrillation. We'll be using the systematic approach to assess these cardiac rhythms found in the 6 seconds rhythm strip, and we'll go over that as well. So cardiac rhythms. In a typical heart rhythm, a tiny cluster of cells at the sinus node sends out the electrical signal. So this here, where you see the letter A in this area here, will be where the signal is sent. The signal then travels through the atria. So this area here, this purple area is the atria. So you have the right atrium, and then you have the left atrium on the side. So the signal travels here, and then it goes to the atrioventricular, or what is known as the AV node. This letter B, the AV node, which is right here. And it then passes through the ventricles. And you can see it. You can see the electrical conduct here, the yellow area here. These fibers, and then this is where the electrical component stimulates the heart muscles to contract and relax, and causing them to pump out blood. A heart rhythm is called arrhythmia if it is an irregular heartbeat. So we will talk about dysrhythmia and we'll talk about arrhythmia, which are sometimes used interchangeably. So the letter A is another Greek prefix that generally means not or without. So not or without. Therefore, dysrhythmia essentially means a bad rhythm, and an arrhythmia basically means without a rhythm. Essentially, they are the same, and you will find that in your textbook, they're usually interchangeable. So each person will say dysrhythmia, and they'll also say arrhythmia, and it basically means the same thing. So how do we calculate the heart rate on an EKG strip with the 6-second rule? How do we calculate this? When you place your leads on the patient's chest, and then that rhythm is transferred to an EKG monitor, then you press the button and then it prints out. How do we interpret this? When you are interpreting an EKG, you must know how to count the heart rate. When you count the heart rate, you are counting the ventricular and atrial rate. So we will learn how to do that. We are going to learn how to count a heart rate using the 6-second rule. So what are you counting? You are counting the ventricular and the atrial rate. There are many ways that you can count a heart rate on an EKG, but I find that the 6-second rule to be the easiest and the fastest way. In addition, the 6-second is great for counting heart rhythms that aren't regular, like your atrial fibrillation, your atrial flutter, your sinus arrhythmia, and your sinus rhythm with PVCs. So it works well in those regards as well. But before you can understand how to count these heart rate using the 6-second rule, you must first be familiar with the squares found on the EKG paper. These squares are found on the background behind the rhythm. So normally it's a pink paper, you'll see some little boxes, and then you see the rhythm hyperimposed onto the 6-second strip. These squares can be hard to see at times, so make sure that you're either using your magnifying glasses or you have your glasses on. Each square and block represents a fraction of time. So when you're looking at the atrium and the ventricle, we're counting the atrial and the ventricular rhythm. We're looking to see how long it's contracted or how long it's relaxed. Okay? We need to interpret what we're seeing on the rhythm with what's happening in the chest chambers, in the heart chambers. So we're going to take a moment and look at our EKG strip. I need you to go ahead and go on google.com and print off one of these 6-second strips so you can practice. You can do that now and come back to the video recording. Once you would have done that, now we're going to look at these little black dots on the top. If you have your 6-second strip, you should have 3 of them. Halfway in between is equal to 3 seconds. So from this dot to this dot is equal to 3 seconds. That means if you were to add up all of these little square boxes, it's going to equal to 3 seconds. From point B to point B, which is the entire length of the paper, is equal to 6 seconds. So your ECG tracings are recorded on this grid paper. You should have one in front of you now. Once you would have placed the leads on the patient's chest, then it's transferred onto the EKG monitor. And from the EKG monitor, it reflects onto this EKG grid paper. Now, you now have to interpret what does it mean. It means that each second is marked by 5 large grid blocks. So here you go, 1, 2, 3, 4, 5. The 5 of them, if you were to count, because each block is equal to 0.04, 0.04 times 1, 2, 3, 4, 5 is equal to 0.2 seconds. Okay? If you were to add up all these 0.2 seconds here, you will get 3 seconds. We will now look further on how we are going to interpret the PQRST using these numbers. So you have to know and practice. So just practice. Look at the EKG grid paper. Know that this entire paper is 6 seconds. Know that within, you see there's a block, there's a block, there's a block. Within each of those blocks, there are 5. Each 5 blocks is equal to 0.2 seconds, and one of these is equal to 0.04. So just say, for example, if your P waves fall on this block only, then you will then just say, okay, that P wave is equal to 0.04. If it falls on 2 blocks, it will be equal to 0.08 and so forth. The next thing that I need you to do is to just go back to the anatomy and pathophysiology of the heart. You would have done nursing 115 last semester, which is pathophysiology, so you should familiarize with that. But just for a review, this is a 7-minute video by Nurse Sarah, how to memorize the PQRST EKG rhythm strip wave. Okay, so just go ahead now, and you can go ahead and click on this link, and you can watch that video for the next 7 minutes and then come back to the rest of your lesson. Okay, so you've watched Nurse Sarah's video, and now we're going to look at the terminology. Electrical firing of the heart. So you have the heart muscle, and then you need this electricity to go through the heart for the heart to contract and relax. So words that I need you to look at is depolarization plus systole is equal to contraction. So depolarization plus systole is equal to the contraction of the heart. Remember when we talk about our potassium levels, potassium helps to contract the heart. Okay, so all of that is associated with your depolarization and systole. Your P wave, this is where your P waves, right here in your atrium, your P waves are in your atrium area, sends out a charge, and then your atria squeezes, or your atria contracts. When you look at your atrium, look at the atrium versus your ventricles. It's your ventricles here and your left ventricle here. So it's your right ventricle and your left ventricle. Look at the size difference. Look how big and huge these ventricles are compared to your atriums. Okay, your atrium is going to deflect a P on your EKG strip. Your QRS is going to be in your ventricles. So when you look at your P waves is going to be a little hump compared to that high spike, which is going to be in your ventricles. Okay, so your P wave sends out a charge, squeezing and contracting that blood. And then your QR waves, where does that come from? In your ventricles, yes. Okay, your QRS wave is initiating your ventricle, sending out a charge, your ventricles squeezing and contracting. All right? So we have your depolarization and systole. So it's happening when you hear your heart squeeze, contract, squeeze, contract. So you have depolarization, repolarization, depolarization, repolarization. Okay? So repolarization plus diastole is the relaxation. So your T wave repolarizes, and you will see in my next slide that your ventricles squeezed and contracted so hard that it leaves a ripple effect, and that's where you see a T wave. Okay, and you have the refilling of blood at that point. All right, you have the refilling of blood. It's pretty much like a domino effect. All right. So what I did here is I drew a little cross. Okay, I can see my cross. And then I have my A, my atriums there, and I have my V, my ventricles. I have my my nodes, my AV, my SA, and my AB nodes. So what happens is your SA node, which is your natural pacemaker of the heart, you would have reviewed that in your pathophysiology class. Your AV nodes, so your electrical impulse comes from your SA node to your AV nodes. And then you have your bundles of His, that is the electrical fiber that runs around the ventricles. And then you have your Purkinje fibers. What is that fiber looking like? Little tree roots that's coming out of the right and left bundle branches. And that sends your electrical impulse, causing the polarization and the depolarization. So look at this this little model that I have here and see if you can remember what I just told you. That to help you understand the misfiring or the abnormal EKGs or the normal firing. So look at your SA nodes, look at your AVs node right here. Look at your atriums, look at your ventricles, look at your bundle of His, and look at your Purkinje fibers and see if you can repeat that. All right. Which of these initiates the P wave? Is it in the atrium or the ventricle? Which of these initiate the QRS? Is it in the atrium or the ventricles? Again, you should have your ECG tracing in front of you. You should know your 6 seconds rule. You should look for your black dots on the top. You should know that each of these is equal to, these 5 boxes is equal to what? How many seconds? Okay, that's good. And this one box here is equal to how many seconds? Okay, good. 0.04 seconds. That's good. From a different angle, we can see the 3 distinct waves produced during the cardiac cycle, which is your P, QRS complex, and your T wave. Once again, which part of the heart chambers depolarizes during the P? It causes the P deflection on your EKG strip. So you can see here your atrium. See the yellow area here? And look right here on your EKG strip. Can you not see the yellow hump? Okay, that's the deflection there. Okay, so you see a full hump there. That's your P wave. Now just look closer if you can and see how many boxes are in there. Remember, this whole grid here is 1, 2, 3, 4. This actually have 4, but it should have, I mean, naturally it's 5, right? But inside of each one of these, you have 5 boxes in there, and you can see uh, 1, 2. So it looks something like about 1.5 there. If you have your glasses, you can see that, okay, or your magnifying glass. So your P wave is caused by your atrial depolarization, your contraction. And it's not as a strong contraction. It's very small compared to the ventricles. Now let's go down to the ventricle area here. Okay, so look here. The QRS complex is caused by the ventricle depolarization contraction. So we already have our P waves there. Look at that little black dot there. That's where you start your QRS complex. But look at this deflection here. It's way up high there. Okay, so that's how strong that heartbeat gets in the ventricles, and now it's going to relax. So it's going to go give you that R wave, and then your S. And so now you're going to see the relaxation here, and then the rest of it is the total relaxation. So this R has to come down, okay? And when it comes down, it's formed into a T wave. That's your repolarization. All right. So look at that. And now you're seeing that it's starting to form on your EKG strip. So here is a diagram to illustrate what I've been talking about. 1, 2, 3, 4, 5. Okay. You have your 6-second strip which would be from point 1 to point 2, which is your 33 seconds, and then from here to there on your strip that you would have copied. But this is a hyperimposed box. So you can see 1, 2, 3, 4, 5 boxes. The 5 of these boxes that are colored black here, 5 of them together, is equal to 0.2 seconds. One block is equal to 0.04 seconds. So let's do this here. 0.04, 0.04, 0.04, 0.04, 0.04. So 5 times 0.04 is equal to 0.2 seconds. So if you have a wave, let me see if I can draw something on here. Your P wave only covers that block, right? Then that means this second, that's how long the atrium is contracted, will be how many seconds? That's right, 0.04. If it is covering 2 boxes, how much is that? 0.08. That is good. It's important to note that each block contains 25 squares. Each small square is equal to 0.04. You have to know this. 5 small squares is equal to 0.2 seconds at a time. So on the EKG monitor, we're going to have to be able to recognize PQRST. P is the depolarization of what? Atrium or ventricle? The QRS is the depolarization of what? The ventricle or the atrium? And the T is the repolarization of what? Good. So those were already explained in the previous slides. We have already covered that in the electrical conduction of the heart. You would have already watched the video from NURS209. In order to understand a normal EKG rhythm strip, you must first understand how the heart generates these impulses. Okay? The depolarization and the repolarization of those muscles and what is reflected on the ECG. So I truly recommend that you understand this portion before you continue with the rest of the lesson. So I would have guided you or instructed you to go and make a copy of a EKG strip from off of the Google. So you should have one of those in your hand. So when you're looking at a telemetry strip like the one you're looking at, you're seeing the electrical impulses generated by your heart through the atrium and the ventricles. And that is then being transferred to the electrodes, which are the sticky patches on the patient's skin, which in turn is displayed on your EKG monitor. At the end of the session, you should be able to recognize atrial fibrillation, atrial flutter, your sinus rhythms, tachy, brady, regular. And of course, we're going to look at some lethal rhythms as well, which is your ventricular fibrillation and your ventricular, besides the points. So here you can see your P wave, that's your little hump there, your P wave, all right? So your P wave is what we're looking at to recognize what is happening in the atrium. Your PR interval is going to be very helpful in looking at your heart blocks, which originates in your atrium as well. Your QRS is your T waves. Your ventricles, your ventricle contracting. And then, of course, your T wave is the repolarization. So your little atrium is giving that little hump. Your large ventricles is giving you that high rise. And then you have your T wave, which is your relaxation. So if I were to say, for example, draw 1, 2, let me just do this as if this was a box. 1, 2, 3 boxes. So you will say 3 times 0.04 is equal to how many seconds? How many seconds? What is that lasting for? Is that prolonged? Is it narrow? So is it prolonged? Meaning, is it wide? Is this number here too wide? Is this contracting too long? Or is it contracting quick, like in your tachycardias? What does this number represent? What does it mean? Okay, we're going to look at that now. So take your time. I'm going to give you 30 seconds here to read this and familiarize yourself. Go ahead now. Go ahead and break this down as well. I'm going to give you another 30 seconds. And again, this as well. So in review, your P wave is the depolarization of both atrias. Relationship between the P and the QRS helps us to distinguish various cardiac arrhythmias. So our arrhythmias generating out of the atrium will be your atrial flutter, your atrial fibrillation, and your heart blocks. Your QRS complex represents your ventricular depolarization. Look at the purple area right here. Okay. Now look at this. They're larger than your P wave. We discussed that because of the muscle mass. And the normal is 0.08 to 0.12. If you would recall, I asked a question earlier. Those 3 blocks, was that a regular Was it prolonged? Was it wide? Or was it narrow? So if that's 3 blocks, if it's 3 blocks times 0.04, it will be equal to 0.12 seconds, which means that is normal. In this section, we'll be looking at the atrial and ventricular rates. Remember, to get your heart rate and rhythm, we need to be able to identify the atrial and the ventricular rates using, we're going to use what's called the 6-second rule. So you should have a 6-second strip in front of you with nothing on it. And then you can now go ahead and pull a sinus rhythm strip. So go ahead and do that now. Once you've obtained that rhythm strip, you're going to identify the P waves. So look at that strip and identify all of the P waves. Count them. 1, 2, 3. You're looking for all those humps. If you see on your strip, I ask you to get a regular sinus rhythm. So in front of each of your QRS, you should have a well-formed P. So beginning at the first P wave, start counting your 30 large squares. So there are those big boxes. Will take you to the end of your 6 seconds. Then count how many P waves are between the 30 large squares. Take that number and multiply it by 10. And this is your heart rate. So take that number and multiply by 10, and you will get your heart rate. It is regular because your P waves are there. We're going to learn that it's regular because following each P wave, you have your QRS. We're going to now identify our ventricular rate, identify your R waves. That's where your ventricles are contracting. Begin at the first R wave. Start counting your 30 large squares because you have a 6 seconds strip. Then count how many R waves are between the 30 large squares. 1, 2, 3, 4. Now your normal heart rate is normally between 60 to 100. So when you're counting, you should not get more than 10 and you should not get less than 6. This number is then multiplied by 10 and this is your heart rate. Here you can see it clear. This is your R, another R. Sorry, I'm saying R. Your P, there's another P. And after each P, you have your R's. Okay, so this is your P and this is your R. Then you have your QR and then you have your R right here. So let's count it. 1, 2, 3, 4, 5, 6, 7, 8. So assuming this is a 8-second strip, sorry, a 6-second strip, this is equal to 80 beats per minute. Okay, so we can see all our R's are there and they're coming regular. When I say coming regular, if I were to measure from here to here, this measurement should be the same from here to here, from here to here. Same measurement, okay? Now just say, for example, this R came right here. There was an R right here. That means this is an irregularity. It's irregular. Do you notice anything different here? Let's go. I want to count my P's, but look at all these P's. There's 3 there. There's 4 there. There's 2 there. But I'm only supposed to be seeing 1. Okay? Something is going on. And where is it happening? Where is it happening? Is it in the ventricle or the atrium? That's right. It's happening in the atrium. Okay? Look at our R's. Let's look for our R's. 1, 2, 3, 4, 5. But if I were to measure from here to here, you can see that this is shorter. It's not the same. This is even longer. Okay? These are not equal. So it is an irregular heartbeat. The P's and R's are there, but there's something happening. And look at this. This is called a fibrillation. Okay? This EKG dysrhythmia, right, is telling you the difference between, remember we were looking at the difference between a flutter and an atrial fibrillation. So there's something happening in the atrium. It's irregular. It's normally a fast beat, but let me let you know this is not a 6-second strip. Okay? If it were a 6-second strip, you would notice that you will have more R's. But you can tell more R's will be coming because an R should not have showed up here. Okay, it should not have showed up. All right. So this is an atrial fibrillation. The heart is beating rapidly and fast and is fibrillating. These fibrillation causes clots in the heart chambers. All right. And these patients are at risk for having strokes because the clots are in the chamber. These are your patients which will be on your anticoagulants. Okay. These are your patients that's going to be on your anticoagulants. This is the patient you're going to be assessing for bruising because the patient on anticoagulants will be bleeding easier. So your AFib, we just discussed that, and your A-flutter are among the most common dysrhythmias in patients. Look at this. Look at our, there's something going on again with our P's. There's only should be one P before an R. Okay? And we can see that there's a 4-to-1 ratio right here. 4 P's and 1 R, not 1-on-1. You can see there's a 2-to-1, and we can see there's a 3-to-1 ratio. If I were to measure from R to R, okay, R to R, you can see it's irregular. Again, this is not a 6-second strip, but if it were, these were coming more quicker than from here to here. But look at it, it looks like a tooth, like a shark teeth. Do you see that? So we call these sawtooth, sawtooth. Sawtooth is equal to atrial flutter. Okay, this is the distinction for your atrial flutter. So go on the internet, go on your textbook, and review some more the difference between atrial fibrillation and atrial flutter. What is the rate and rhythm? This is indeed a 6-second strip. So you can see your R's here. Did I hear 11? Did I hear 11 times 10 is 110? Which rhythm is greater than 100? Your sinus tachys. Your sinus tachys are greater than 100. Which rhythm is less than 60? Your sinus brady. Sinus brady will have your R and it will have your P. So your P will come first, followed by your R, QRS. Your P will come first, followed by your QRS. Okay? It's going to be regular. R to R is going to be regular. It's going to be regular. If the rate is less than 60, it's your sinus brady. If your rate is greater than 100, it's your sinus tachy. So we know that this is a fast beat. We said that our atrial beats are fast, and we said that tachy beats are fast. So let's find out if this is a tachy beat or is it an atrial beat. So now we're going to look for our P's against R's. Look at that. Look at all these P's coming. Look at this. Look at all these P's coming before this R. So does that not look like fibrillation to you? Yes, it is. Okay? So it's a fast beat. It's an atrial fibrillation beat. One other thing I want you to just draw to your attention is your prolonged, what we call a prolonged PR interval. So when you have your P, this is your P here, and you can count these boxes in here. 1, 2, 3. Okay? When you count your boxes, 3 times 0.04, we get 0.12 seconds, will be your P waves, right? But when you now add your R, P to R interval, then you are now looking to see how long the PR interval is. I mean, how long it's contracting. That means the longer it contracts, the slower the heartbeat. We already said that your P waves give you the fast heartbeat, all right? So from onset P waves to the onset of QRS, normal duration is 1.12 to 0.2 seconds, all right? Which is equal to 3 to 4 boxes, all right? So if you say 3 and 4 boxes, it's going to give you 0.12 to 0.2, all right? So all you have to say 3 times 0.04 is equal to 0.12. It represents your atria to ventricular conduction time through the bundle of his. However, if you have a prolonged PR interval, it may indicate a heart block. That means anything that is longer than 0.2 is going to be equal to a possible heart block. All right, and you can see the deflection here on this wave. Remember, we talk about arrhythmias and dysrhythmias. I want to draw your attention to 2 lethal rhythms. Your Tassats the points, which looks like a tornado right in here. And your fine, you can see here, ventricular, the ventricles are fibrillating. All right? Both of these represents heart attack, an infarct or an ischemia. Ventricular fibrillation, that's why you say defibrillate. You call for the defibrillate. You want to defibrillate the heart. It's dangerous type of arrhythmias. It's an irregular heartbeat. A VFib occurs in a variety of clinical settings, but more so in your MI, your infarction. And let me just say, it starts off when you have, just drawing this, your T waves are elevated. Okay? When your T waves are elevated, it could mean hyperkalemia. Go ahead and read up on that this weekend. Or it can be the fact that you're having a MI. When your T waves are inverted, you see that right here? It means that you can have ischemia, some low oxygen or no oxygen. Is for your MI, and ischemia is low oxygen for ischemia. All right. You can also have an inverted from an old scarring, so meaning that you would have had an MI before and that area never healed. So it may not be that they're having a heart attack. It just means that there's an old MI. It also can mean hypokalemia. Okay, the muscles are not contracting. So without that muscles and blood going through to the heart, you end up with either one. And in return, you end up with Tassats the point. That's this one here, which look like the tornado in the middle. And then you have your fine contractions here, but it's going erratically as your ventricular fibrillation. Like I said, the treatment for this is defibrillate. Signs and symptoms of abnormal heartbeats will be from your atrial flutter, your atrial fibrillation, your Tassats the point will be found under the term collapse. Collapse indicates that your patient is unstable. So your patient may faint. He's going to have a low oxygen saturation, may feel lightheaded. Because he's not being perfused. His blood pressure is going to be low. He's going to be anxious. And as you can see, it spells collapse here. Anytime you're starving for oxygen, you're going to be anxious. He's going to have palpitations, which is the irregular heartbeat. He's going to feel it in his chest. He's going to say that. Shortness of breath. because the brain is starving for oxygen, is gasping. You're going to show dyspnea. The heart rate is going to be fast, and then the patient is going to be feeling dizzy, or any one of these symptoms may be associated with your irregular or your lethal heart rates. Your treatment goal is surrounded by what you're seeing here. Your normal sinus rhythm comes out of the SA nodes. So it originates out of your SA node, which is your normal pacemaker that beats about 160 to 100 beats per minute. Less than 60, sinus bradycardia. More than 100, sinus tachycardia. So NSB is the same term for normal sinus brady. NST is the same term for normal sinus tachycardia. What do you want to do for a patient that is stable or unstable is give these drugs. This is a homework I want you to go over. When you look at atropine, what are you giving atropine for? Atropine speeds up the heart or slows down the heart? To give you a hint, it speeds up the heart. So which one of the rhythms? Okay. If adenosine slows down the heart, which one of the rhythms you want to treat? Good. Cardioversion, is this for atrial fibrillation? Is transcutaneous pacing for sinus bradycardia? Is defibrillation for ventricular fibrillation? And is epinephrine and CPR? There's no heartbeat, no breathing. You give CPR, right? So is there a rhythm called asystole? Yes, there's a rhythm called asystole, in which you will give your epinephrine. So review those as well. So in summary, you have your ST segments, your T wave, and your QT intervals. For your ST segments, because we looked at P, we look at our QR, and now we look at our ST, which is the relaxation of the ventricles. And the duration should be 0.8 to 0.12 seconds. How many boxes is that? If one box is equal to 0.04, that's 2 to 3 boxes on your T wave. So your T wave should not be high or it should not be low. And it should be within 2 to 3 boxes. We know what ventricular fibrillation and to sides the point is going to look like on our EKG monitor, and it's caused by an MI, coronary artery disease, or ischemia. An MI occurs when a coronary artery, one of the artery supplies to the heart muscles, becomes suddenly blocked. So there's no oxygen. Ischemia is when there's low oxygen. The sudden blockage robs the portion of the heart muscles of blood and oxygen to supply, and that portion dies. So a heart attack is the death of a part of the heart muscle. Okay, so the patient's going to complain of tightness in the chest, radiating down the left arm because there's no oxygen supply. You are to go to these two videos, a 25 minutes and a 15 minutes video. The second video right here is the interventions, nursing interventions. The part A speaks about the pathophysiology and the definition, the diagnostics. Sickle cell anemia is a genetic blood disorder that affects the shape of the red blood cells. As the nurse, you will want to be familiar with the pathophysiology, the signs and symptoms, the sickle cell crisis, the treatment, and nursing interventions. Remember, nursing interventions includes assessment, therapeutic actions, which are independent and dependent actions, that warrants the doctor to write, which will be the dependent. And independent is something that the nurse does to help fix or alleviate the cause. And then, of course, education. So sickle cell anemia is a genetic blood disorder. Why are we talking about blood in the cardiovascular system? Because the cardiovascular system comprises of the heart itself, and we just looked at some of the heart issues a few slides ago. It consists of the blood vessels, which would be like a coronary artery disease, and then or your cholesterol, and then it consists of genetic blood disorders, or blood disorders such as sickle cell or even hypertension. Hypertension could affect the heart, it could affect your blood, it could affect the blood vessels. And so this is why we're looking at blood disorders as sickle cell anemia is classified as a blood disorder. What is sickle cell anemia? It is where a person has abnormal hemoglobin S. Normal hemoglobin is hemoglobin A. So they have abnormal hemoglobin S. Remember, we talked about the body needing oxygen, glucose, and then the body responds in an inflammatory response. In this case, the body is deprived of oxygen because that A is not what we're seeing. We're seeing an S. This type of hemoglobin is very sensitive to oxygen changes, which causes the red blood cells to change its shape. So the body is looking, it's trying to maintain its homeostasis, it's looking for that oxygen, so it changes its shape just to get that oxygen. This then results to a complication where it's called sickling, and then you end up with a sickle cell crisis. Sickle cell anemia is the most common and the severe form of sickle cell disease. How do people get sickle cell anemia? They're born with it. The person inherited the 2 hemoglobin S genes from each parent. Therefore, it is where we see the body has a recessive disorder because they have 2 of the same genes that can cause the sickling to occur. This means in order for sickle cell disease to occur, and because this patient would have inherited the 2S, those 2 abnormal hemoglobin genes from each of their parents, they now have homozygous hemoglobin SS. The patients normally don't show signs and symptoms of the disease. They will each possess hemoglobin A and S, 1 normal hemoglobin and 1 abnormal. This is known as sickle cell trait. So some of you may be sickle cell trait. You may have one of the abnormal genes, which is CS, and then you may have 1 normal. And they don't normally show signs and symptoms. It is rare for people who have sickle cell trait to show signs and symptoms because they usually have just enough normal hemoglobin to prevent the sickling of the red blood cells. However, if 2 people with sickle cell trait have a child, there's a 25% chance that the child will develop the sickle cell because remember, both of those parents are carrying the S genes, those with the traits. Pathophysiology of sickle cell. How should a red blood cell normally look? It should be round, it should be smooth, and it should be concave, with flat centers on both sides and contains no nucleus. Because the red blood cells doesn't contain a nucleus, it can easily squeeze through our vessels to accomplish the job. So what does this tell us about the S? It's telling us that it contains a nucleus and it's going to be very difficult to squeeze through our vessels to carry that oxygen. As we know, our body wants oxygen. That's what it wants. So what's one of the jobs of the red blood cells? It's to carry oxygen. And it does this with the help of hemoglobin. For the red blood cells to achieve this, it must have hemoglobin A present. But what does the sickle cell patient has. They do not have the hemoglobin A. They have the hemoglobin S. So they need the A present so the shape of the red blood cells won't change. These red blood cells then stick together so well that they will cause circulation problems. They cause an obstruction. And with the obstruction comes what? Pain. And this is when signs and symptoms will manifest itself in a sickle cell patient. These red blood cells stick together, so it causes a problem in the circulation. It's important to remember that most patients with sickle cell anemia will usually just have anemia, and they won't have major signs and symptoms until a crisis episode. So something has to happen, something has to trigger the crisis, and so they will remain anemic, low oxygenation, fatigue, poor growth and development until a crisis occurs. Then you will start seeing the pain and all those different things. So when the red blood cells stick together, these abnormal shape cause the red blood cells to become stuck in the vessels. Like I said before, blocking blood flow. So organs and tissues suffer, which then leads to what we know and we see in the patient. The patient is in pain. So we need to get rid of the crisis, and then the crisis will then help with that sickling, because we know that the patient normally is anemic anyway. So it's the crisis that really aggravates this process. A decline in sickle cell crisis manifests local tissue damage. And why is this happening? This is a pathological process that is caused because of the obstruction in the circulatory system. This is what's causing the pain, the tissue damage. When you have tissue damage, that means there's lack of oxygen going to that area. There's sickling of the cell. Where does the anemia part comes from, though? What does that mean? We know where the pain comes from. Where does the anemia, the low red blood cells come from? Red blood cells with hemoglobin S are very weak and easily ruptured. So the person who has sickle cell, when they produce their hemoglobin, it's going to be weak and it's going to be easily ruptured trying to go through those vessels. And they only live for 20 days compared to the normal 120 days. So every 20 days, this person is trying to make red blood cells. Then they use it up, but the normal red blood cells takes 120 days. So the body just can't keep up. The bone marrow cannot keep up with producing these red blood cells. So the patient is indeed anemic. Which patient population is most affected by sickle cell anemia? African Americans. As we know, the Bahamas, we're 97% Black. We're in the Caribbean, and we tend to have physical traits of that of the African American. So we should see a lot of that in our population, 1 in 12. So when we talk about 1 in 12, for every 12 person, one person more than likely will be carrying that S genes. If you carry that sickle cell trait gene, which is the S, and you meet another S, together you create an SS, and hence the population, and this trait is easily passed to your offspring. How is sickle cell trait diagnosed? This disorder tends to be diagnosed in the very young population. So we begin to see it early in life, like around 6 to 8 months of age. And many times a parent will notice their baby is all of a sudden extremely fussy, like the child is in constant pain. Remember, pain was one of the clinical manifestations. They may have fever. Fever can cause the sickle cell crisis and has unusual swelling in the hands, okay? Dactylitis. Dactylitis is a hand and foot syndrome where the mom will notice that there's swelling in the hands and feet of this young baby. That right there is where the obstruction is occurring. And of course, the inflammatory response system is also going to kick in as well. These signs and symptoms present because the baby's red blood cells have started to sickle and cause extreme pain. The sickling decreases blood flow. Remember that. It decreases blood flow. So no blood flow going to that extremity, and that organ causes obstruction and low oxygenation. Ischemia equals pain. You've seen ischemia doing something before with the heart, okay? Ischemia in the heart equals pain. Same thing. A mother may ask now, why is this occurring now and not at birth or around 2 to 3 months and 5 to 8 months later? It's because in the utero and during the first 6 months of age, the baby has fetal hemoglobin. Remember, this because we talk about this type of hemoglobin for the treatment of this condition. So one of the treatment is the fetal hemoglobin. And it's they were able to take it and put it into a drug called hydroxyurea. In this system, that is the main carrier of oxygen. So the baby still has some of the fetal hemoglobin that's protecting them. So that's leaving the body at this time, and hence the baby's now on its own circulation. However, around the age of 6 months, this type of hemoglobin diminishes, and the type of hemoglobin their genetic code give them takes over, which unfortunately is that SS and the sickle trait. So sickle dex is a blood test. So we're talking about diagnostic now that assess for abnormal hemoglobin S. It doesn't differentiate between if the person has sickle cell trait or sickle cell disease. So you can test the baby with the sickle dex and they can be positive, but we don't know. There's not testing to see if they carry the A as well. Therefore, hemoglobin electrophoresis will need to be performed. This is a blood test that assesses for the various types of hemoglobin. Of course, the sickle dex is cheaper than the hemoglobin electrophoresis. Types of sickle cell crisis. You have the vaso-occlusive. Vaso is in the vascular, is occlusive, it's obstructive. It gives fever, pain, swelling in the hand and foot. It's especially seen in babies. The red blood cells sticks together, blocking blood flow, which can lead to decreased circulation to the organs. Decreased circulation to the organs means the organs are not going to function properly. We're going to look at that in another slide. Tissues along with infarction. So infarction, remember we came across that word, myocardial infarction, stroke, and renal issues. Hyperhemolytic is the other type. Destruction of red blood cells as an accelerated rate. So you have the normal person having it at 120 days. It's already at 20, decreased down to 20, and it's being destroyed rapidly. Red blood cells carry oxygen. Oxygen causes you to think, move around. So the person's going to have brain fog. They're going to be fatigued. They're not going to have good growth spurts. When red blood cells rupture, what do? They release bilirubin. Put a lot of strain on the other organs. Normally the body, gallbladder and spleen can keep up with recycling of red blood cells and clean up this bilirubin every 3 months, 3 to 4 months. However, we're talking about every 20 days now. That's a lot of work, a lot of overload for two organs that was used to doing this over a 4-month period. However, this is not the case in sickle cell anemia. The person can experience jaundice as well, gallstones and anemia because we've overworked these organs, the gallbladder and the spleen. Aplastic is another type, the halt of red blood cells production, period. The bone marrow cannot keep up with producing these red blood cells, so the patient will cease in making red blood cells. So what are you thinking? Yes, this patient gonna need some oxygen because they're not having, they're not producing. They're gonna need something else, maybe a blood transfusion. Non-functional spleen. The spleen helps recycle old red blood cells and filters the blood to kill off foreign invaders. So if your spleen isn't working, you are susceptible to getting sick because you're going to be exposed to these pathogens and before your spleen was able to help you. In sickle cell anemia, the spleen becomes so congested, and that's why sometimes you see those sicklers, their abdomen is distended, okay? It's big because of the engorged spleen. which leads to swelling, and it's not working properly. This patient is at risk for infection, and the doctors may have to remove the spleen. Keep in mind that surgery also increases their risk for sickle cell crisis as well. Crises vary among patients. Some can have them randomly, while others may have them more frequently. It's just no telling. The patient needs to be hydrated, they need fluid, they need oxygen, they need pain medication, right? Early signs in baby, dactylitis, normally around the 6 months. Remember, this mom, fetal circulation is leaving them. The blood flow being blocked to the hands and will be swollen, and fever will be present. Of course, the patient's going to have pain, very severe, in the back and the joints, so we need some pain medication. I said anemia, they're going to need some packed red blood cells on board. So because the RBCs are dying too soon, patient's going to be tired, they're going to be tachycardic, pale, short of breath, and of course delayed growth. We keep mentioning that. The mucous membranes are going to be dry. Infections are going to be at risk because the spleen is not able to fight off those foreign invaders, so they're going to be at risk for pneumonia. They may need one of the things you want to educate them on is their pneumococcal vaccine, their flu vaccine. And some patients may need the spleen to be removed, splenectomy. Gallstones, why? Because sickles, red blood cells are constantly breaking down and releasing bilirubin. That's the end result of your red blood cells, which leads to gallstones because there's too much bilirubin for the gallbladder, and like we say, the spleen to manage. Other signs and symptoms are strokes, eye problem, risk for abnormal clotting and leg ulcers. And you can imagine why. Because the red blood cells stick together, they cause blockage. And with this blockage, increased blood coagulation. We talked about DVT and we talked about PE in our pulmonary lecture. And of course, leg ulcers, because lack of blood flow, it's going to be painful, and it's going to be very slow healing, because if there's no flow going, there's no oxygen. Oxygen carry nutrients to the cells. Another will be the acute chest syndrome. It happens due to infection like pneumonia or embolism or sickle cells blocking perfusion to the lungs. They're going to have the chest pain, so we need something for the pain. They're going to have a cough, fever, low oxygen saturation. They're going to need oxygen. New chest x-ray with infiltrates. That's going to be shown on the x-ray. Then we need to monitor their respiratory status. Also, the kidney, damage to the organs that depend on high blood flow. The kidney needs a lot of oxygen going through those renal arteries. If that doesn't happen and it blocks that blood flow, then you're going to lose that kidney. The patient could end up in end-stage renal disease, liver disease, heart disease, because the blood flow is limited. I started to include some of those nursing interventions earlier. So sickling of the red blood cells occurring, we need to focus on hydration. Remember, one of the causes is dehydration. We need pain, medication, antibiotics, oxygen, their respiratory status. We need to monitor, assess the respiratory status, monitor their neurological check, because we could have occlusion, obstruction going to the brain, lack of oxygen there as well. Acute chest syndrome, we need to monitor that chest x-ray. We need to give them their CPT, chest percussion therapy, provide a prevention of future crisis episode. We need to educate them on that. Medications, and of course, blood transfusion for the anemia. Some of the pain medication include opioids around the clock. PRN, not the best time until the crisis is over. And that's one of the errors that we make here. We normally give the patient morphine Q 2 hours, PRN for pain, but we already know as long as that patient is in crisis, they're going to be sickling. So you don't have to ask, are you in pain? They will be in pain. So you need to give them that medication every 2 hours. Take a moment now and look up the word PCA. PCA pump, patient control analgesic pump. Look that up. That's something that we do not use here, but is a device that is hooked up to the patient, and the patient is able to get that medication around the clock without the nurse's intervention. So please look that up. We'll have further discussion on that later. Other nursing intervention includes, we already talked about the oxygen. Now the antibiotics will prevent infection. So some doctors will have you take it prophylactically because we already know that the spleen is compromised and this patient is at risk to develop acute chest syndrome. So they will put them on that prophylactically. So when you're giving your report, don't say the patient has an infection. Make sure that he has an infection because it may just be a prophylactic, just to ensure that he doesn't get the infection. Blood transfusion to replace the red blood cells. Remember, the bone marrow may just stop working, they plastic, to keep the anemia from getting worse. And watch for multiple transfusion because that can cause iron overload as well. Bed rest is another nursing intervention. Patient's going to be painful and not wanting to move around. You can imagine that foot is low oxygen, is ischemic, is ulcerated. We might want to administer folic acid. That's a therapeutic dependent action. It helps make red blood cells and not iron. This doesn't help with this type of anemia, but can actually build up in the body, causing toxicity and harms to the organs. So be careful with that. Educate about preventing infection, need for their vaccines, staying away from high altitudes, smoking, staying hydrated, staying away from physical and mental stress. So these last two slides, I want you to go back and forth between them and put the category. Is this an assessment? Is this a dependent action? Is this a nursing action? Is this education? Remove restrictive clothing because it decreases perfusion. That's a nursing action. You know, the doctor doesn't need to tell you that. That's a therapeutic nursing action. Warm compressors, not cold, leading to sickling for painful areas. That's a therapeutic nursing action as well. All right. We talked about hydroxyurea. This helps actually treat cancer, but it will help with the sickle cell anemia that it will create fetal hemoglobin. We talked about that. This helped decrease sickling episodes, especially in this protein first present in babies 5 to 6 months. It will also help with the anemia, decreasing the need for blood transfusion. And we always hear them on the radio calling for blood transfusions, and we're pretty much low on red blood cells. So this is a good choice here. All right. The side effect, however, is it lowers the white blood cell count. So what does this mean for this patient? If your white blood cell is there to help fight off infection, you're knocking down the WBCs. This patient again is like a double whammy. It's another increased risk for infection as well. And finally, you can look at stem cell transplant to cure. Bone marrow will make healthy red blood cells, but they need a match and a donor to make this happen. Unfortunately, their brother or sister may also be carrying that same trait as well. Hypertension. The definition of hypertension is the amount of resistance of blood pumping through the body and the arteries. Remember, cardiovascular deals with blood vessels, so we're looking at the arteries here. Sickle cell looked at the blood itself. Okay. High blood pressure, hypertension, is a common condition. Common condition, not a disease. It's a condition. It's not an injury. It's a condition caused by long-term force of the blood against the artery walls. It is high enough that it may eventually cause health problems such as heart disease. The normal is 120/80 or less, looking at your systolic and diastolic. Pre-hypertension, of course, would be anything greater than 120 to 139. So within that period, within those numbers. And then you have stage 1 and stage 2. So stage 1 is 140 to 159, and stage 2 will be 160 over 100 and greater. Keep in mind this is the primary or essential hypertension. Unfortunately, hypertension, HTN, is also known as a silent killer because people live through the pressure. They live through that pressure on their back, in their head, the pains in their shoulder. And they go along with their daily living and they progress from pre to stage 1 to stage 2. When the patients start to have signs and symptoms with hypertension, their major organs may have already been affected, such as their kidneys and their eyes. Signs and symptoms of severe high blood pressure includes headaches, because the pressure is so high going through those small veins, arteries, nosebleed, fatigue or confusion, vision problems, chest pain, difficulty breathing, irregular heartbeat, and blood in the urine. The cardiac system, it causes congestive heart failure, because remember we said it may cause further problems. So congestive heart failure. We're going to cover congestive heart failure in one of our upcoming lectures due to the overworking of the heart muscle, which makes it become enlarged. We talked about that left ventricle earlier today. So that left ventricle has become enlarged and it loses its elasticity. This brain stroke. So increased pressure weakens the blood vessels, which can cause a clot. When you have a clot, there's no oxygen to form or from them to rupture. Then you have low oxygen. You just have a stroke. So either way, it's a stroke, but clot and then ruptures. Kidneys, renal failure, weakening and narrowing of the arteries to the kidneys. And the kidney don't receive proper perfusion, no oxygen. Eyes, visual changes, the damaged blood vessels to the retina. The patient have blurred vision and cannot focus on image. So most of the times it's in middle-aged individuals more so, and they may think it's something to do with aging, but in actuality it's something to do with their high blood pressure. So continuing with essential causes. Unknown causes. Look at the risk factors known. The risk factors for hypertension are race, being black, being a male, increased consumption of salt, smoking, and stress. So as we know, blacks retain salt and sodium. And there you are, you're increasing your consumption of salt and alcohol. And wherever salt and alcohol go, there goes water. Okay? So you have all this water and the patient becomes dehydrated. Being a male, the testosterone constricts your blood vessels. So you have a lot of pressure in this vessel and is already constricted and you're hypertensive. And smoking and stress also cause constriction as well. Potassium level and vitamin D levels are low. Keep in mind that low potassium causes myocardial ischemia, low vitamin D as well. What happens with black people? We tend not to go out in the sun, so we already have low levels of vitamin D. Family health, that means it's something that you would have inherited. Getting older, your heart is just weak, tired, cholesterol is high, bad eating. You're drinking too much coffee, constriction of the blood vessel, obesity, clots, obstruction in the blood vessels. Restricting activities causes obesity. Eating bad food causes obesity. And sleep apnea. All of those can be causes of essential hypertension. There's something called secondary hypertension. It's caused by pre-existing issue. There's something causing the person to have high blood pressure. Pregnancy, Cushing syndrome, chronic renal failure, diabetes, hypothyroidism, all of that causes. So you will, in your patients who come to the emergency room or who's in hospital, may present with hypertension, may not have a family history, may not have on any of those risk factors, but here you have it, renal failure. Regulates fluid, regulates blood pressure. The kidney does that. All right. Hyperhypothyroidism also. This patient may present with extremely high blood pressure. A tumor in the adrenal gland, which causes adrenaline to be secreted also increases blood pressure. So when you are looking for your cause, you want to see what the cause is and then you fix it. Because if it's related to pregnancy, well, the pregnancy needs to be released in order for that blood pressure to go down. So you have to give them the medication to assist while while the patient is pregnant. If the patient is hyperthyroidism and it warrants the thyroid being removed, then that is when you're going to see the changes in the blood pressure. Remember your assessment. You're going to assess for headaches, blurry vision, chest pain, nosebleeds, ringing in the ears. All of these are common signs of high blood pressure that people tend to avoid, and that's why it's a silent killer. You want to assess and evaluate. Assess and evaluate are the same thing. Measure your blood pressure in both arms. Make sure the patient has been in a resting position for 5 minutes. This is the proper way to do your blood pressure. The patient is not smoking because that causes vasoconstriction. Ask about your family history. If they have any change in their vision, in their hearing. You want to evaluate the blood pressure reading. You have to familiarize yourself with the stages. You want to know the dietary intake because of obesity, and you want to know the body mass index. Is this patient 25% overweight? BMI. Yes, you want to know all of that. You want to educate, limiting sodium, alcohol, caffeine, quit smoking, start exercising for loss of weight. You want to keep them with their medication compliance. You want to measure blood pressure regularly and bring it to the doctor's office so they can see a trend. So all those will come under education. And you want to do that while the patient is there. You want to ask them a question. The same time they come into the doctor's office, you want to be able to have those questions ready for the patient. So in the next few slides, I actually presented the medication listing. Remember, you have your heart, which is the muscle. You have your blood vessels, and you have blood. Each one of these medication works on something else. Like say your thiazide, your diuretics, that works on the blood. So if this person has retention of sodium, that would be a good drug to put the patient on. So I'm just going to slide through them. You're going to take your time and you're going to not memorize it, avail yourself of what it does and when this patient should be getting it. So these medications are normally implemented after you would have done exercise and eating changes. And if the patient does not have any reduction in his blood pressure, then you want to start him on these drugs. Okay, so you have your thiazide diuretics. Look to the bottom. Make sure you're looking for your nursing action. Okay, look for your nursing action here. That's related to this drug. Any drug ending in ARBS, your ACE inhibitors, that increases potassium, so you want to monitor your potassium level. Your CCB, calcium channel blockers. You want to watch for bradycardia. You want to make sure put this patient on an EKG monitor. Your beta blockers. You remember we talked about asthma and COPD. We want to stimulate their beta cells. So if we're stimulating their beta cells, you do not want to put them on beta blockers because beta blockers is going to do the opposite. It's going to stop those alveoli from opening. Persons on beta blockers, you want to monitor their glucose level because it can conceal signs of hypoglycemia. So go through each one of these. Educate your patient on dry cough, your ACE inhibitors. Avoid potassium supplements because it causes potassium to increase, so therefore you want to monitor your potassium levels. Cardiogenic shock. These are your signs and symptoms, your risk factors, your diagnosis, some more diagnostic tests, and then your nursing interventions. Okay, so you can go ahead and review those at your own pace.